For the next hour about how critical mobile tools are in low resource settings, as they're often the go-to source for providing training, data collection, monitoring, and diagnosis. Our panel will converse on what innovation the future holds for better ways to provide improved care and outcomes. Organizing the panel and moderating a portion of the panel is June Sugiyama, Director at Vodafone Americas Foundation. And I also want to just say that this panel in particular was also sponsored by the Vodafone Americas Foundation, so we're very grateful for that as well. Thank you very much, and then June, I will turn it to you.
Hi, everybody. Like mentioned, I'm director of Vodafone Americas Foundation. Vodafone has 26 foundations worldwide. As you know, we are a mobile telecoms company, so it would make sense that we would support mobile innovation in the social sector. I run the foundation here in the US, and we run a large challenge once a year called the Wireless Innovation Project. And the people you will see here are the people who have won in the past in our competition. As you know, this panel is about health tech in low-resourced area. And what's really interesting is at lunchtime I was talking to some of my pals, and they're like, well, what's low-resourced? Is it like private practice where you don't have equipment and depending on who your clientele are? Well, that's not necessarily the low resources that we're talking about, but it could be some of our solutions could be adapted to that kind of setting, but we're talking mainly in developing countries, working in areas where they don't have equipment, clinics, doctors, and most of the people who are providing care are field workers. So, why mobile? I mean, I already told you that we're a mobile company, but the fact that there are over 6 billion mobile subscribers around the world, and that would be the easiest tool that's accessible in all corners of the world is probably one of the reasons. And the fact that innovation it is happening in mobile, whether it's money or health or monitoring or social services, is happening on mobile. And one of the reasons I wanted to make sure this panel was here, mainly because I don't think the philosophy of build it and they will come is a good one in mobile health. Good in baseball, but not in mobile health. And so it's really important that we provide a value added to you in the audience about what kinds of challenges are out there and how these people who have been successful so far have dealt with those challenges. What kinds of things you should look out for is what we want to provide to you. So in order to provide what would be best for you, I wonder if I can take a quick poll. So are there physicians, practicing physicians in the audience? Okay, a few. Okay. Developers and entrepreneurs. Okay. And then like health, insurance providers. Okay. And I'm not quite sure what the others are, but NGOs. NGOs, yes. NGOs in the audience. Great. Thank you for reminding me. So, panel, now you know what kind of audience we have. We actually have a treat, and I put a twist into our panel. I thought rather than me, who's like a basic funder, ask the questions, it might be good to have someone who's a practitioner, who uses the tools, who's been in low resource settings to be asking the questions. So we have a treat. We have Dr. Enoch Choi, who's a practicing physician with Pacific Medical Center.
Palo Alto Medical Foundation.
Palo Alto Medical Foundation. That's going to be, I will be moderating, but he'll be probably asking most of the questions. So Without further ado, I would like to start out with Dr. Bruce Kahn to talk about mobile ODT.
Good afternoon. Thank you for having me. Thank you, June, for allowing us to come. This is what I came to talk to you about today. I'll show you that in a little bit more detail. A little bit about myself first. My name is Bruce Kahn. I'm a gynecologist. I work at Scripps Clinic in San Diego. 90% of what I do is take care of patients and do patient care. The other 10%, which is really probably 40%, I teach. I do research. I do a lot of common research that clinical academic physicians do, but this project has been probably the most fun one I've worked on. So my involvement is with Mobileodt. It's a company based in Tel Aviv. It's a startup, and they are working on a mobile application for cervical cancer detection. That's it in its simplest form. This essentially is a tool, just a plain smartphone, nothing high-end, moderately priced. Put it into a 3D printed apparatus with a lens on it. This turns this into what's called a mobile colposcope, okay? So with that said, I want to back up now and give you the big picture of kind of Mobileodt. I'm here representing them. My relationship with them is just as a researcher for the most part, and we applied for the Vodafone Americas Foundation grant to do testing of their product here at Scripps in San Diego a little bit, but we also have a partnership with a clinic in Tijuana, so we're doing, and branching out from there, so doing some testing there of the device and going from there. But a little bit more about this concept here is cervical cancer is why they picked as their target market for this. There's a whole bunch of applications for this device, and hopefully I'll finish up mentioning some of those other possible applications. Cervical cancer is the #1 cancer killer of women in the developing world, or in those low resource settings. So cervical cancer for this company, looking at, there's a bunch of different kind of cancers you can try to detect with this, but cervical cancer, since it kills thousands of women every year in these places where women don't have access to pap smears, they figured this would be a good place to start. So a woman in the U.S., a woman who goes in for her pap smear, has it done. For a woman who has an abnormal pap smear, she has to come back and have what's called colposcopy performed. Colposcopy is microscopic. It's a microscopic view of the cervix. Vinegar is put on the cervix to see if it's abnormal. Abnormalities are biopsied, and then perhaps a little portion of the cervix needs to be removed. This is why in the developed world we don't have a lot of cervical cancer, because of pap smear screening, HPV testing, colposcopy, treatment for preventing cervical cancer. However, in the developed world we don't have that. Non-governmental organizations that do some outreach in other areas of the world, they use kind of a low tech form of colposcopy, if you will. What we have, the kind of the best thing we have is put a speculum in and put some vinegar on the cervix and eyeball it, and if it turns white, okay, that's abnormal, and then they can do a treatment, which is cryotherapy, freeze at their cervix. It works well, but unfortunately, 6 out of 7 women that get their freezing done didn't need to have that done. It's a cheap treatment. It's only $30, but if you do that 1,000 times, you waste a lot of resources. So what if you could use this cell phone to help image and do colposcopy either real time or remotely? And then the highest level use of this is what they're working on. There's a bunch of different uses of this for preventing cervical cancer. The highest level use would be, well, take this image and how do the light waves interact with the tissue? So if you've ever been to the dentist and they look inside your mouth for screening for oral cancers with ultraviolet light, it's that kind of concept. How do the light waves interact with the cervical tissue? And if you just simply took an image and had a Wi-Fi connection and had an algorithm, a database with an algorithm attached to it, and that could give that provider there at the scene an instant answer of treat, don't treat, which would be much more sensitive than just the eyeball, potentially take the same dollars that are used and be able to prevent a lot more cervical cancer than currently is done. So that's really, for me, it's fascinating. It's been a lot of fun. We're working on developing, like I said, several different applications of this. Even in the US, could we make it so that women don't have to come back for a colposcopy if they have a low-level abnormal pap smear? That's a great question, okay? Because a woman gets an abnormal pap smear and it causes a lot of anxiety. It causes, they have to wait to get the appointment to come in, and there's a lot of resources spent on it. So even that is a simple question, could be a huge improvement in care in the developed world and developing world. So, in deference to Mobileodt, I think they've done a good job developing a product with a bunch of different applications potentially. Even for, lastly, I'll mention sexual assault, domestic violence. They take this thing in an ER and document, and this is connected through a mobile app to a secure database. So could those images go into secure database? Could you take images in the ER, bruises or other things, have those available for later on if they were needed, sort of thing. So that's another application they're looking at early on, in addition to a bunch of different cancers. So that's Mobileodt. I will go ahead and let the other people speak.
Thanks, June. Hi, everybody. I'm Eric Douglas. I'm a co-founder and CEO of Cellscope. And we got to know June actually back in 2009. So Cellscope came out of a project that I was doing as a postdoc at Berkeley on mobile microscopy. So our lab, led by Professor Dan Fletcher, was one of the first groups doing mobile imaging on a smartphone, starting back in about '06 when phones were starting to get cameras. And we got excited about, our lab did a lot of biophysics and basic microscopy and kind of high-end microscopy. And what could we do to bring that to the phone and take those out into the field? And so we developed a number of different microscopy applications. And initially the focus was really around things like tuberculosis and malaria, doing blood smears and sputum smears. And some of the work that was supported by the Vodafone Foundation was looking at, for example, TB sputum smears in Uganda, where we could take these devices, inexpensive devices, out to the field, be able to have a technician prepare the slide and put it into our device, take the images, and send them off to a remote doctor for analysis somewhere else. And we learned a lot through those trials, and I'm happy to talk more about that over the course of the panel, but really continued to try and drive the devices towards what are simple applications that are going to meet important needs. And so myself and another one of the people in the lab, Amy Sheng, spun out the company Cellscope Inc. In 2011. We joined Rock Health, the incubator in San Francisco, and started thinking about kind of the low resource setting of the home. This kind of spectrum of what low resource settings are, where it's, in this case, it's what can a family do? What can we provide to moms and dads and individuals at home to meet common healthcare needs? And so that's where we started developing what's now become our first product, Cellscope Odo. So I'd love to give you all a demo maybe afterwards if you have troublesome ears or are curious, but our little module here, this has optics inside it, and it has a light pipe that draws the light off the flash from the phone. And it turns the phone into a high-quality digital otoscope. So you won't be able to see that, but you can get the idea of you're traveling through the ear canal. Imagine you're a parent, you wake up on Saturday night, 2 a.m., your child's tugging at her ear, and you have to decide, do I take her into the urgent care? Do I go to the ER, make an appointment for Monday? All those are crummy options. We're trying to make it so families can get really easy access to convenient, high-quality care immediately from home. But then also, kind of a next generation aspect of it is building up a lot of the data we can collect from those encounters and driving towards more automation and tools to help the caregivers provide triage and decision support. And so that's something that feeds back into the way we look at low resource settings. Being able to automate some of the analysis, being able to provide diagnoses and provide triage at the point of care immediately based on what we can do with these high volume of really high quality data that people haven't had access to before. So the otoscope is a place to start. I think it's a complementary concept to what he was describing with the colposcope. I think this area of doing mobile imaging is a really exciting and burgeoning field. So I'd love to talk more about that over the course of the panel.
Hello. Nexleaf Analytics, we're actually a nonprofit tech company. And so we work on solving public health and environmental issues with low-cost sensor and data analytics. About tens of millions of dollars are spent on vaccines to be shipped to developing countries all over the world. And there's studies that estimate up to 33% of these are no longer effective by the time they're administered. And so this is a significant problem, and there's a lot of effort being put into trying to solve it. So we're focused on trying to keep the vaccines effective in the last mile of what's called the cold chain. This is the remote clinics that have a single refrigerator, and are, maybe holding them up to a month or two, and will be administering these to children. From our perspective, the real problem is a lack of data. So no one knows what exactly is happening with these refrigerators, and so no one knows what's really happening to the vaccines. Are they freezing? Are they being exposed to heat too long? What really is the problem? And as a result, everyone sort of gets stuck. If the fridge is broken, they're not quite sure what to do, or at the district level, they just don't know where to send the vaccines, if the fridges are working or not. And all the way up to the national level, and also with organizations like UNICEF and Gavi, they all want to know, as they're pouring money into distributing these vaccines, are these efforts effective? So what we've built is a system called Cold Trace. It's a piece of hardware and a system. The hardware is essentially a remote temperature monitor. It measures the temperature of the refrigerator and transmits that data over the cell network. It also sends out alerts and reports to various levels in the health system. One of the things, since we're an NGO and we're not just focused on sort of building hardware and pushing it out there, one of the big things we do is try to make sure that all this data we're generating actually gets integrated into the health systems. So a significant portion of our effort is working with the ministries of health, working with partner NGOs that are sort of embedded into the health system to make sure that people understand how to use all this data that's generated, everyone knows what the right actions are, and this data can actually unstick the system. So the maintenance guy knows where to go. The folks at the national level know what are the best fridges for the environments they have in their country. There's a whole large set of analysis that can come from just the temperature information. Additionally, it's about taking that data and integrating with other systems. So in some of the countries where we work, there are existing sort of stock management systems that track and manage the distribution of vaccines. So those folks now can have an understanding of, as they're distributing or about to make a plan for distributing vaccines, they can make better informed decisions. So we've been able to do this work with the very supportive funding from the Vodafone Foundation, Vodafone Americas Foundation. We also have had funding from the Gates Foundation and Google.org.
So as you can see, we have different kinds of innovation just within our panel that are here today. We look for innovation in 5 different areas: education, health, access to communication, economic development, and the environment/disaster relief. In developing countries, technology alone or the hardware solution alone is not enough. I mean, we need to have some sort of measurement, and also when we have special equipment, there needs to be some training. So one of our winners in the very, very early years that we started our competition is Ken Pak's innovation from MIT called Sana.
Can you hear me? I have a tendency to talk softly and mumble, so wave your hand if you can't hear me. 30 seconds on my background. Former life, I was a software engineer, went to medical school to learn the clinician perspective, took a vacation in business school, focusing on technology strategy and entrepreneurship, and found my home in clinical informatics, basically studying digital health solutions and data mining in healthcare. I spent 50% of my time at MIT focusing on big data, healthcare analytics, secondary use of clinical data, and 50% of my time on Sana, which is mobile health, global health informatics in rural and resource-limited settings, and then another 50%, you can do the math, is in digital health startups and such. So Sana is kind of a complicated organization to meet a complicated problem, obviously, in using mobile health tech solutions in the developing world. As June mentioned, the bottom line is that technology solutions alone aren't enough. There's a lot of problems, infrastructure, resources, and unique challenges in the global sphere that we in Ivory Towers can't just say, let's drop this technology that we use commonly into this unknown area and expect it to work and to yield strict benefits. It's not just about improving access. You have to focus on quality improvement. That's why we do bring in clinicians and public health experts on our projects. And thirdly, one of the key points is that these solutions have to be sustainable. As many of you in NGOs and that do work in the global health arena, we suffer from a culture of pilotitis where, we start a lot of interesting projects, but very few of them continue beyond and actually make a long-term sustainable impact. So our particular approach is focused on collaboration, bringing multidisciplinary teams, which has been a recurring theme throughout. But we fortunately can bring in clinicians, engineers, business, public policy, public health people all together to work on these solutions because you need to make a systemic change in order to make a sustainable impact. We also focus on co-creation, so working closely with people on the ground, people, partners, collaborators that are from those local international regions because they know the cultural intricacies and significances better than we do and know what will work in their local environment. And thirdly, with a focus on sustainability, we really encourage capacity building. We have limited resources that want to work in global health, but then we can't always just take people from Boston, San Francisco, LA, and drop them into, they can't rely on perpetual grant funding or people from international NGOs in order to support them. In order to be sustainable, you have to have people on the ground in order to drive the innovation in the local region. So we have 3 major initiatives to support this. We have an open source telemedicine platform, which I won't dive too much into, but this is what a lot of our projects are. So through our incubator, we support some projects, and I actively participate on a few of them, a wide range of projects in many different areas. But then we also focus on capacity building, and this takes the form of education, textbooks, and publications, and boot camps and hackathons in particular in country where we try and bring in local engineers and stuff like that. So that's why this slide is here. We have core academic partners from our that work together with us at our course at MIT and Harvard, HSD 936. Anybody can take it if you're interested, where we bring in international engineers to work with local Boston students to actually hack on live projects that we work on. And through that, we allow these projects to get an initial kickstart in order to get to the next stage. And then we also run boot camps and hackathons. So our general program sequence for our international projects is, we start off with a boot camp where we bring in engineers, expose them to mobile health concepts and theories, and to understand that healthcare itself is very challenging. It's not like many other problems that engineers commonly encounter. And then we run a hackathon where we bring in clinicians to work together and network with engineers to experiment and hack and play around in that area. Unfortunately, I'm sure many of you have experienced hackathons, and they're great for generating energy and great for creating connections. But to get to the next stage, you do need more structured mentorship and guidance, and that's what our course is for. And also, and it diverges to some of our projects really focus on research, clinical research, and evidence-based medicine, a very clinical effectiveness approach, and then others look at social entrepreneurship and other alternative business models to sustain them. And so currently we have a lot of active projects in Brazil, Haiti, Rwanda, Lebanon, Colombia, and Greece. And we're going to be going to a bunch of international regions. Colombia is in a couple weeks, Greece is later in the year, Mexico, to run these boot camps and hackathons, and hopefully start some interesting projects in those local regions. So thank you. That should be it. Right. Excellent.
Thank you very much, Ken. Thank you, panelists. So what we're going to do is we'll have Dr. Choi ask some questions to start out, and we'll leave the bulk of time for the audience space to ask questions, because I'm sure there's some things that you want to find out from our panelists. So,
So my first question is to Ken about your course at MIT and the sustainability and training questions. What are the parameters for applying open source processes in these lower resource settings? What are the consequences and the costs associated with that?
Sure. So I'm sure most of you have heard the term open source. I'm not sure how many of you have actually used open source software and technologies actively developed on it. Good. So the bottom line is that open source does allow for increased access for a lot of these countries who can't afford licenses and seats for traditional for-profit software. But the caveat is that open source doesn't mean free. You do have associated costs with any project that you deploy. It does reduce essentially the activation barrier to adopting technologies for your particular project, but most projects will require customization, so customization and maintenance. So those are intrinsic costs for any project, and generally, with the advent of Linux and other type of a lot of very successful open source projects, they are more cost effective than closed source projects, but you do have to consider those things in any project that you deploy.
Thanks so much. My next question is for Eric about how adaptable your product is. How do you build sustainability within the project? What does that look like? Is that the same process for the different applications of your technology? Because one cannot live by grants alone. One must become profitable sometime.
Sure. Yeah. Yeah. I mean, that was part of our transition into thinking more about the at-home use cases. With the original applications that were around things like tuberculosis and malaria, we had a hard time coming up with how to make it sustainable, and it's sort of continued as a very successful academic project within the lab at Berkeley, and continued to do a lot more groundbreaking work. They just had a paper out last week looking at monitoring blood for Loa parasites in low resource settings, which is a serious problem, and that they could do it in a very automated fashion, just taking a drop of blood and wicking it into a channel and having the software and hardware actually process that all automatically and detect the parasite. And that's really important groundbreaking work, but I think in order for us to think about what was going to be the model to keep it sustainable, we turned more towards the at-home applications, towards applications like the ear infection and other things, getting into kind of common visits for skin issues, eye issues, things that bring kids and families into the doctor, and coming up with ways to make it easy for the doctor and the patient to interact remotely on that and for them to get compensated.
Thanks so much. Bruce, I've got questions about your partnerships. After the data is collected, who finally delivers the care? How are your projects completed? You talked about a number of different applications. Who are these local resources and the workforce that provides that clinical care? Can I try that out? Who provides the training for people like me who want to try it?
Right. I don't want to be a politician, but if I can I kind of answer that part of the other question first, and it'll tie into that? So, how do you make it profitable? How does the company make it profitable? It's how do you pay for it? Get off the grant stuff. Again, we're using grants to do the research, but once the company has a pretty good idea of where they're going and working with private organizations, large private healthcare providers in low resource settings, but also with NGOs. They have a pricing structure for NGOs for the device. There's a charge for the device, $800, $1,800 for private clinics sort of thing, so relatively inexpensive. A little charge, yearly charge for their database. Who's using the device? I think we can kind of deploy it on, it can be deployed in several different ways, and so we're working on several different ways to do it. There's not much training to do it. It really just show someone how to do it. The app is pretty easy to do. Someone does need to show them how to do it. We're working on developing a project with Planned Parenthood in San Diego and Imperial counties, the two southern tiers in California. And Imperial County is the healthcare there. The healthcare status of women there is kind of like a very low resource setting in itself. The unemployment rate in that county is about 25%. So we're working, say, with Planned Parenthood, somewhere like that has fairly sophisticated low-level providers that can go out in the clinic. Can they take images, share them with a colposcopic expert remotely somewhere in San Diego, do that. You could do that anywhere in the world. So from Botswana, you could be, someone could be looking at that image in Boston, and that Partners in Health at Harvard is actually doing some projects like that. So it's very flexible, to answer your question. It's a very flexible scheme to look at and then the end result one, the light analysis one, that will be somewhat automated, would be the ideal thing. So take an image, get an automated answer, and the healthcare worker gets that answer directly. That's a couple years down the road before we get there. But again, in the meantime, there are some things that are can be profitable to develop the resource.
Great, thank you. Martin, I had such a pleasure chatting with you again over lunch, and your technology is something that I find so important because in my own free homeless clinic, our vaccinations, I told you, are frozen twice. So this technology that you have seems to be so critical. How do you find and pick the partners that you work with? How important is it to piggyback on the existing projects that you have, the local workforce that's actually bringing these vaccinations and delivering them and deploying them?
For us, we've been fortunate to be able to find partners that actually have the data that we generate, the data that our systems generate, gives more value to what they're doing as well. So I mentioned that we're working with one NGO and one actual social enterprise, one in Mozambique, one in India, that are building out systems that do what's called LMIS, Logistics Management Information Systems. So they're tracking and helping decide where and how to deliver the vaccines and other medical supplies. This data only enhances their system. So we're a very small organization, but these other companies, they have a significant on-the-ground effort. They have relationships with the ministries of health, and so that really sort of helps us, and then helps us with our foundation funding to go in and sort of explore the problem and try to fine-tune and figure out what is the right way to develop the technology, get the data integrated sort of into the culture, sort of build a culture around the data use, both for the data we generate and also for the systems they're building.
I had a following question just about do these initial big funders really kind of direct you to work with some of their existing projects on the ground, and you leverage the infrastructure they already have that Gates Foundation and these folks have already in these health-related deployments?
It's both. The organization we're working with in India, we actually met them because through the Vodafone Americas Foundation, we were competing for the same thing, and they ended up for other work they do with Gates Foundation funding as well. And with the other organizations, it's funding comes to us and we support them, or funding comes to them and they support us. So it's all sort of mutual. Then the funders help facilitate that in some cases.
Thank you.
Symbiosis. Yes.
Healthy symbiosis. Erik, I had another question for you about thinking beyond the innovation. How do you incorporate additional resources? How do you make it better? How do you rev it? How do you break it and rev it, make it better? Do more than, and sometimes it sounds like do less to help people with ear infections diagnoses at home. Were there other resources developed in the lab that you applied to these new products that you developed?
Yeah, thanks. And I wanted to start actually with another part of the answer to the first question. I think it's, I was saying, part of it is doing new different types of exciting research in the lab, but I think it's also, it's hard to find grant funding to make tools, like to do tooling, to make a product, to do productization, to do the stuff that leads to starting the company. And that's kind of the gap you have to get over to actually, apply the technology, have it come to fruition in the wild. And so for us, it was a matter of thinking about how to take the basic concept, turn it into a product that we could find a business model for, but still with a longer-term view toward how that could be used, in a very low-resource setting, kind of all over the world. So it wasn't that we gave up on using it in low-resource settings. It's that we kind of realized that we had to adapt the model to make it something that was broadly applicable, and that we could turn into a product, and where we could find different sources of funding that would, in this case, VC investors, that would help us turn it into a product that had a profit motive, and in addition to our motive to want to help solve these important healthcare needs. I think that's also part of the answer to how to make it better. As we think about getting beyond the initial technology research we were doing, and turning it into a product, we have to think carefully about what need we can solve with that product, and then how we can do it really well, how we can continue to improve on it. And for us, I think the big insight, the big change over the last few years has been really moving towards that data-enabled model, where going from just sending images for remote diagnosis into how can we provide that full end-to-end care? How can we take the data we have access to and turn it into algorithms and turn it into a real service that can help meet the needs both for people here and for people around the world? And so it was being pushed to refine it into a product, and being pushed to refine it into something that actually met a full pain point for real users, that helped us both refine, narrow in one sense the idea of the vision, but also improve it to the sense that we could actually make it worthwhile for people to use.
Thank you.
One last question.
One last question? Okay.
Yeah.
So let's see. Martin, how did you pick your first project tab? There's so many possibilities. Why the solution, and how did you pick that? How did you choose that low-hanging fruit?
So we were actually working on remote temperature monitoring, but in sort of a different space, in the cook stove space. And just through various partners and colleagues, they sort of helped us put together, make some connections. And it's us having sort of experience in taking wireless sensing and applying it to collecting data and applying analytics that let us sort of hit the ground running. We were deployed and piloting 3-4 months after we got our first grant for this. And there's we're still learning about the vaccine space and everything. It's really been an amazing experience. So, yeah.
Great, thank you so much.
Thank you, everyone. Now, I'm sure you have questions in the audience, but before I open it up, what we've noticed in running the competition and the character of the winners is it's not necessarily something we were looking for, but we found that all of our winners had certain characteristics, and that's why they became winners. One is that they weren't just complacent with this product that they were developing, that they went beyond that. And the product that they started out with might not be what they ended up with. And by what I mean by not staying complacent, they, like Martin was talking about data. They weren't just concentrating on the tool itself. They knew that it produced data. What do they do with data to be more impactful and effective? They partnered with other NGOs, other organizations that could use that data. And then sometimes that data creates sustainability. You can sell that data. And then they didn't stay complacent with just the first iteration that was successful. They keep on adapting, they keep on developing new formats, and then they keep on developing new uses that they never even imagined in the very beginning. So those seem to be the common factors in all of the winners that we've had so far. And then all of our winners, almost all of our winners have gone on to get more funding beyond ours. So they leverage our funding, winning our funding and our name, and then go on to get more funding. And they've gotten not just one partner, but several partners. So with that, does anybody have any questions for the panelists?
So can you hear me? So most of the time at the hackathons when you go, you have 2 or 3 people who have their idea and then they try to hide so much till the end of the competition, and there's something they're passionate about it. Why can't it be done the other way, where you have a business problem, you have the stakeholders who say that we need this product to be built, there is a grant behind it, and then have people come in, the right guys come in and build it for you. And eventually they have a stake and they say we will spend another 1 or 2 years around it, rather than the other way around, where you have these guys trying to go and figure out, like, for instance, that's a good product that he has for the vaccinations, but if all the players who actually have a stake in the game are there, you get this prep before the hackathon, like maybe 6 months, 7 months, 8 months, and say, these are the things we want to build, and then see if people come in who have a long-term interest, build it. I mean, is that a viable thing to do?
Ken, you want to answer? Yeah.
Sure. Not to speak for the other panelists, but that's generally our approach for boot camps and hackathons, where we bring the stakeholders, both public health and clinicians who have identified a problem and connect them to the engineers to work on these solutions. The one caveat is that sometimes, especially clinicians, I'm a clinician myself, and especially in, I don't want to speak too negatively about our international brethren, but they have a tendency to be more paternalistic and less open to change than here in the U.S., or particularly the coastal U.S. So that's one of the challenges where sometimes they think they already know what the problems are and know what the solutions are and are not open to exploring new ideas. So that's why I think it's really great to bring in engineers like these guys to create interesting solutions. That's why you need the hacking and the prototyping, just to experiment what will actually work, because we are limited by resources that are available, and sometimes they create great inventions that we can't think of before we actually get there.
Yeah, and then it's also the downfall of some hackathons where you don't have the stakeholders there in place. You only have the funders, let's say, and then you only have the coders. And then you don't have the actual people who are going to use it in the end, who can give you feedback on how, or the sustainability factor, the people who will take it on and fund it, right? So if anyone is doing a hackathon, you have to make sure all those ingredients are in place. I remember being at one hackathon where people from Ghana were online through Skype, and they were, on time, providing feedback with what was being created.
Forgotten the fellow's name, but the one you're looking at home applications, parents using this for children and whatnot. How do you envision selling them the accessories, if you will, and making sure they know how to use them so that they could participate in this? And do you also envision potential partnerships with teledoc kinds of organizations where maybe they're the distributor? I don't know.
Yeah, I think there's kind of three main channels. It could be either directly through retail, it could be through their doctor, or it could be through a telemedicine, teledoc type organization. And I think they all have different kind of pros and cons. What we're finding to be most successful so far is working through the doctors, having people want to work with their own doctor. They have that established relationship and trust, and so if they see their doctor using it in the clinic, then they and the doctor says that they could also use it at home, they're often very interested in that. We also, for the ones who have a real pain point, the frequent flyer type users, a lot of them are just buying it from us directly, and then we can connect them with third-party doctors on the back end for the diagnosis.
Yeah, they have the packaging, and they're already marketing, so we should be seeing them in drugstores pretty soon, right?
Yeah.
Yeah. Next question. Hold on.
When we talk about digital health technologies, there is a whole spectrum of technologies. Some we have seen about population health, and on the other hand, we have these wireless medical devices. So you have higher hurdles to cross, like regulatory, FDA's 510K or reimbursement. How do you kind of, from each instance, has overcome that? And from a market perspective, how did that respond?
Good question. Who wants to take it?
I could.
Okay.
I could take that one. So I think that was a big part of how.
Let's rephrase the question.
Oh, sure.
The question, how did you hear it?
So I take it to be developing a product in digital health has a lot of barriers, including regulatory, reimbursement, all the usual healthcare challenges, and how do you pick which market to address, and how do you trade that off against what the challenges are going to be? Something like that. For us, it was a matter of starting with the technology and looking at all the different areas that we could address, and then looking at which ones were big markets, which ones actually were common problems, and then trying to figure out which ones would be the simplest and most actually achievable. And so in our case, we found the ear infection to be a good place to start because it's the most common reason kids go to the doctor, and it's also, from a technology perspective, pretty straightforward for us to achieve. But it also gives us a good base on which to grow. So we can start with the basic kind of Class 1, 510K exempt digital otoscope, and that's what we're marketing now, and then moving to layer on new capabilities to that. So it gives us a base of having a product out, having people using it, generating data, improving the product, and then as we add in the algorithms and additional capabilities, we can have that kind of base camp from which to address those other markets.
And if I address it, again, I kind of mentioned a little bit, but you need to go after the low-hanging fruit. That's the best way to put it. And what's the easiest thing to get to? For our device, it's cervical cancer. Huge problem, easy to get to, but there's so many other applications for it, and that's just the beginning. So that, I think, is the beauty. And I think June addressed that a little bit. The device, the things that have, I think, the common thing to success, hopefully success, is something that has something that's easy to get to, but also multiple applications that are a little harder to get, but build on that.
Great, thank you very much. We have, before Dr. Choi leaves, I just wanted to thank Dr. Choi. He has to run to another panel.
Moderating another panel in 4 minutes.
So if you're a fan of his, you can go to the next panel. But he's an avid diver. He works with the homeless in the Palo Alto area, and he's also done relief work after the typhoon in the Philippines, and he'll be going to Nepal in August to do some relief work as well. And he loves technology, especially in his health work, so that's why we have him. Thank you very much. So I'd like to provide you with extra time and opportunity to meet and look at their products. So at this time, I'd like to close this formal session, but in no ways is it closed to you to talk to our panelists. And thank you so much to our panelists. Some of them have come on an airplane to come over here, so I appreciate it very much. Thank you. And thank you, everyone.